So, can you hear me? Okay. So, good afternoon, everyone. My name is Satish Modi. I have a small practice in a very small town in the Hudson Valley in New York. We're about a block from Vassar College. For the last decade, probably 43 to 48% of all our cataract surgeries have been premium lenses. And we have a very strong research department. I'm a certified principal investigator, so we're kind of honored to be part of one of the 12 surgical sites in the country that were involved in the PanOptix trial, which as I told somebody today, is going to be a slam dunk for the industry. So what I'm speaking on at this point is my personal clinical experience, which now dates to 2 years ago, the FDA data review, and then since approval, the first 30 days of what we've been doing. So we had only 127 patients who were implanted with a PanOptix in the trial. So we were only allowed 10 patients each. So we had the trifocal lens. I have 10, as you can see, 12 of the monofocal, and overall these are data on 22 patients. And as you can see, the ages are pretty similar. 65. Average age was 68 years. So, for those of us who don't look in logMAR, when we talk about Snellen acuity, let me just refresh your memory. 0.00 is 2020, minus 0.1 is 2016, all right? And 0.1 and 2 and 3 keep going from 2032 to 2040 to 2050. All right. So when we looked at the uncorrected visual acuity and the distance-corrected visual acuity, you have the trifocal in the top, the control monofocal on the bottom, and as you'll see with the distance acuity, these patients, distance unassisted acuity was better than 2020, both with the PanOptix as well as with our monofocal. So they saw beautifully for distance. All right, but when you start looking at intermediate, and again, for those of us who don't go metric, 66 centimeters is 26 inches. So at 26 inches, the PanOptix was still better than 2020 on every one of my patients, and it drops to about 2032 when you look at the control. Then when we looked at near, 40 centimeters is 16 inches, 15.75 to be precise. Again, the PanOptix was better than 2020, uncorrected, and we dropped to about 2040 to 2050 when we looked at the near vision. So there was a marked change, and this is all visible. So let me go back to this. This is an interesting slide. What they asked was, how many of our patients at all three distances saw a certain amount of vision, all right? So you can see the light blue is the control, the PanOptix is in dark blue, and you can see that 100% of my PanOptix patients saw 20/25 or better. Whereas with the control, you can see that at all three distances, it dropped precipitously with the control, all right? And what's really phenomenal is 4 out of 9 of my patients that completed the study saw 20/15 or better, all right? And this is at all three distances, distance, intermediate, and near. And the defocus curve really tells it all. Those of you who are using multifocal, bifocal type lenses are familiar with the double camel hump of the defocus. So what you have is a hump at 0, and then another hump, depending on the implant, at 2.5 to 3 diopters. And here you can see predictably the monofocal, the dark blue, drops off to 20/50 as you go from distance to intermediate to near. But all of these patients saw 20/20. And the defocus curve is as flat as it gets here. So this is the cumulative data review from the study. Again, you can see how you've got 20/20, 20/25, and that's the logMAR. And it's really very, very flat. It goes from better than 20/20 at 0 to 20, and remains at 20/20, both at 26 inches and at 16 inches. Perhaps the only slight drop is down to about 20/25 at a little over a meter, at 39. How does it do this? Well, The PanOptix is actually a quadrifocal implant where one of the peaks has been truncated. So it's moved that light away from 80 centimeters, all right? So what happens is 88% of the light goes directly into the eye, so the contrast sensitivity is really very good. 50% goes to distance and 25% to intermediate and near. And what I love about this is it's not apodized. Therefore, there isn't a differential light transmission for distance versus near, depending on pupil size. So these patients, and we measure mesopic pupil size on every cataract patient, and I don't worry about mesopic pupil size anymore, because what happens is these people, even with the large pupils, can read in a dimly lit restaurant, and that's huge. So this is an animation, I believe, of the implant, and I'm going to shut up for a few minutes.
And Acrosoft IQ PanOptix toric IOLs are innovative trifocal lenses that offer you the thrill of delivering
and unlike other multifocals, you can see it's only a 4.5 millimeter zone. It doesn't go out to the edge of the optic.
Is equipped with advanced Enlightened optical technology, a proprietary design that optimizes intermediate without compromising exceptional near and distance vision. The unique diffractive structure allows the lens to transmit 88% of light to the retina at a 3 millimeter pupil size for exceptionally high light utilization. Featuring a 4.5 millimeter diffractive zone, Enlightened optical technology helps reduce dependence on pupil size in different lighting conditions. To create Enlightened optical technology and to make it possible to achieve 20/20 near, intermediate, and distance vision, Alcon reimagined multifocal performance.
Sort of mirrors a defocus curve. It's all flat.
At 120 centimeters. Then, we redirected the new focal point's light energy
which is what
distance.
I just said. The truncation moves it to distance.
Optimally placed focal points, one at 40 centimeters near, one at a 60 centimeter intermediate, and at distance. The result is visual performance that breaks free from tradition. With the PanOptix IOL, it is now possible for patients to achieve visual acuity of 20/20.
Incidentally, Alcon has a beta model of the simulator for your counselors, which is absolutely phenomenal. I just looked at it yesterday, and it is excellent. It'll make your counseling so much easier in the office.
PanOptix IOL.
So at the end of 6 months during our study, we asked every patient, any buyer's remorse? All right, if you had to do it all over again, would you have the same implant again? And 99.2% of patients said they would have the same implant again. So let's talk about my first 30 days. It's been 30 days since it was approved. It's been a roller coaster ride. It's been wonderful, absolute slam dunk. So first let's talk about what is a good candidate for PanOptix implants. I've got to tell you, practically everyone, so long as they have a normal macula, a normal cornea, and no media issues, all right? It corrects T3 to T6, so it corrects 1 diopter to 2.5 diopters of astigmatism, including giving you near, intermediate, and distance. And other than cost issues, there's no reason why I wouldn't put this on every patient. I'll certainly have it in my eyes. So our counseling, especially with the Restore, with the apodization, used to be, well, if you've got a large pupil, you're going to need an extra light to read in a restaurant or what have you. That discussion has gone by the wayside. Now we don't talk about that because these people can read at every pupil size. The only issue is that if you have someone who drives a lot for a living, a truck driver, taxi driver, what have you, you do need to assess their risk profile in terms of rings. Or so, going back to the study, when we talked to the patients at 1 month compared to the Restore, these patients complained more about the rings at 1 month. At 3 months, it became a conversation. And at 6 months, they'll say, well, if you push us, yes, I can see it. It doesn't bother me. All right, so you do have to counsel them a little more about the rings. And if somebody's anxious about it, I think that it's a discussion that one needs to have and maybe choose a different implant. But that would be the only exception. So we called back one of my first patients. She's 2 years post-op. She was part of the study. So she was a 50-year-old female. She had some cortical changes at 2+NS. Her vision dropped from 20/40 to 20/80 with glare testing, and her slit lamp exam and retina were both normal. So we looked at the pentacam. If you look up over here, she has about 0.7 diopters at 105 degrees in her right eye. So we were not allowed to do RIs. We were not allowed to do LRIs in the study. So I felt comfortable with this, all right? If it was the other way around, I would not have done her in the study. But so she had 0.7 diopters of width of rule in the right eye, half a diopter at 80 in the left eye. So she had a little bit of width of rule astigmatism. I'm fine with that. In fact, I aim for about a half a diopter width of rule. Now, the two takeaway pearls I have for you here are, number one, we were not allowed to optimize our A constant. We had to use the A constant out of the box for the study. All right, so for those of you who are starting PanOptix, it's an excellent starting point. As you can see, we had great results. All right, so you really you should be comfortable using the A constant on the box. We're in the process of optimizing. So for those of you who use Aura, it's globally optimized for Aura because it's been available outside the US for years. And within 1 month, we will be personally optimized. But so we're putting all the data into Aura. But the key issue here is all of us aim for a little bit of myopia, especially in the non-dominant eye. Don't do that, please, with the PanOptix. Aim for plano. As much as you can, aim for plano. That's what you need to be hitting as a target. All right. So we're in the process of acquiring the Ingenuity, the 3D system. And for me, what was, and Rob Weinstock just spoke about it, but what to me was really incredible, and this is us at first day, is apart from the ergonomics where I wasn't leaning over a microscope through the whole thing, what amazed me was once the lighting, the color saturation, and the focus was done, I focused on the crypts in the iris. I took my foot off the foot switch for the microscope. I did not have to change the focus through my whole case. I was focused from cornea to the posterior capsule without any issue. And the other thing is that my Verify Plus came up on the screen, so I knew exactly where my axis was. I saw my numbers on the screen. So all the way to the right, you'll see my Aura, and then you have your Centurion, and then this, and the Luxor up there. Everything is visible on this 55-inch screen right in front of you. And this is one of the videos. I'm 100% femto-based. The incisions, the side port and the primary incision are beautiful. They seal every time. It's optimized our surgically induced astigmatism. And while this is going on, I'll say that we looked at 40 consecutive toric patients and looked at Aura. And I presented this data at ASCRS in San Diego. And Dave Lubeck, I couldn't make it to ESCRS, Dave Lubeck presented it for me in Paris recently. We found that using a combination of LensX and Aura, 94% of our patients were within a half a diopter target. You can't get that without automating the steps that are really critical to achieving good astigmatism control. And this lady had a little bit of against the rule astigmatism. You'll see in a moment there's a small RI at about 15 degrees, and it's the easiest thing in the world to take a 30 gauge cannula with a tuberculin syringe, and it opens up so easily. And I think I'm... All right, so I'm already in. So you notice it's critical when you do Aura that you have the correct pressure. If you want consistency, you've got to be consistent. So I put in more viscoelastic. You can see my Aura, my Verify Plus coming on, measure it, and put the implant in. And here I am with the 30 gauge cannula opening the nasal RI. And it's very easy to do. And you can do it at the slit lamp if you don't want to do it in the OR. Needless to say, it's on the Acrosoft platform. These lenses center beautifully. I must tell you, this is my first day using the Ingenuity system. I had a certain amount of trepidation because I was operating like this, but it went beautifully. I had absolutely no issues whatsoever. Okay. So this is this lady. We called her back. She's 2 years post-study. And you can see each eye sees 20/20 for distance, intermediate, and near. And the cumulative additive effect is she sees 20/12 -2 for distance. And her posterior capsules 2 years out are pristine. I haven't yagged her yet. And so we have an unadulterated video of her speaking about her experience.
Hi, we're here with one of Dr. Modi's patients who had the PanOptix.
I can't hear anything. Can anyone hear anything?
Both of her eyes while we're in
Can we
the
hear?
FDA study. So the good news is she's been living with this lens for 2 years almost. Can you tell us a little bit about your vision and your experience with the PanOptix lens?
My vision's been wonderful. I have no limitations at any distance. I work on a computer all day. I've had to wear glasses for distance since I was 15 years old. So all of that is gone. Loving it. It was a great thing.
How's the reading vision?
The reading is great. No restrictions on that. I did get to a point in my life in my late 40s where I was adjusting my papers so I could see. I no longer do that.
Can you talk a little bit about night driving and how that vision is?
That is at one point when I do notice, I do see rings, especially if it's raining at night. But you know, my normal duties and living is not hindered by anything, and certainly the trade-off for being able to see at all distances is worth it.
Thank you.
You're welcome.
So our first 30 days, did I say this or talk about this? I can't tell you. Within a 100-mile radius, one of my colleagues, his wife, 50 years old, bilateral PSC, has had myopic LASIK, has had blepharoplasties, and he sends her to me to have PanOptix. This woman, who used to be a -6 diopter myope, is seeing 20/20 for distance and up close. I have done a refractive lens exchange on a fellow who's 6 feet 6 inches tall. So this guy's got a long wingspan. He works over here. He's had no issues with his intermediate vision out to 1 meter. And of course, he's reading beautifully. We have somebody with a multifocal lens that was done elsewhere in one eye. I put a PanOptic in the other eye. They've adapted and prefer the PanOptic eye. And then we've done a bunch of bilateral standard PanOptics. But this has been our roller coaster. And they've asked me for a quote why I'm a PanOptimist. Because frankly, this implant overrides anything else available in the United States. This is the closest approximation you can give your patients to normal human vision. And this is why I love this lens. So, 20/20 for all 3 distances, their technology, 99% of the patients would have it again. I would have it in my own eye. Thank you.